We are live.
Okay, so good morning, everyone. And I am Dr. Gaurav, and it gives me great pleasure to introduce Dr. Venkatdass, sir, today for our Fellows Academic Round. Dr. Venkat is a renowned pediatric orthopedic surgeon from India and abroad also. He is very known, and he is leading the pediatric orthopedic department of one of the finest institutes of India, Ganga Hospital. He has a lot of practice changing papers in his kitty, out of which one of his favorite, one of the most popular paper is about pink pulseless hand, its evaluation and management. And today, sir would be speaking on supracondylar humerus fractures, the vascular and nerve injuries. So I've always aspired and admired sir since the time I have been introduced to pediatric orthopedics. And it's a great pleasure to introduce sir. Without wasting much time, I would request sir to share his screen and start his talk. After sir's talk, we will take the questions, and questions are invited in the chat box, please. Thank you. Sir, you are mute.
Thank you, Gaurav, for the wonderful introduction. So without any further ado, I'll directly dive into the topic. I think you had a brief discussion about the supracondylar fractures last week by Dr. Nirmal from Chandigarh, the fellows who are attending this fellows academic round. So the idea of today's session is that we want to sort of give a practical orientation to how to go about when you see a child with a supracondylar humerus with associated neurovascular injury. And the most important thing is the pulseless supracondylar humerus fracture. So I'll just touch upon the current concepts of how we evaluate a child when we get a supracondylar humerus fracture, and also give a broad perspective of how to go about when you are practicing in different places. From place to place, the practice might change, and I'll just give you the outline as well as the principles which you need to remember in the mind when you come across a child with a supracondylar humerus without pulse, as well as with associated nerve injuries. So this is a burning issue in most of the conferences. If any pediatric trauma meeting or a conference will not go on without at least one talk with a pink pulseless hand. The incidence of neurovascular injury is about 10 to 15%. So this is a burning issue because of the moral responsibility as a pediatric orthopedic surgeon or an orthopedic surgeon treating the child. We don't want to give a lifelong disability to the child, because if you don't manage it appropriately, and particularly if it is a dominant hand, and it can be a lifelong disability to the child. The second important thing is, which you should remember, is the legal implication which is attached to the pulseless supracondylar humerus. So when you deal with the pulseless injury and you land up in complications, you have legal implications also. So these are the reasons why this is a burning issue all the time. And on top of it, there are controversies of how to manage, because there are no proper guidelines. That is the reason why people keep on asking questions of how to weigh, should we manage myself or should we refer, or things like that. So when you get a child with a pulseless supracondylar fracture, so these are all the sort of questions which you can get in your mind if you're a practicing orthopedic surgeon. So whether first question is whether I'll be able to manage here, or should I refer to a center where the vascular work is done routinely on a day-to-day basis. And the second question is evaluation of the child. Should I get a Doppler to confirm that there is a vascular injury or a brachial artery rupture or an angio, or should I call for a vascular surgeon to help? I can fix the fracture. To fix the vessel, should I call a vascular surgeon? Shyam, can you tell me what will you do? What do you do when you get a child with a supracondylar humerus fracture?
Yes, sir.
Without pulse.
Yes, sir. Sir, firstly, I will see if it is perfused or not, if extremity is perfused or not.
Okay.
And if it is perfused, then I will do close reduction.
Okay. So you are right in a way that we should assess perfusion of the limb. And before going on to the perfusion, the most important part which I want to stress here is the clinical examination of the child. Good clinical examination. Oftentimes we see that whenever a child is presenting with a supracondylar a pulseless supracondylar humerus, it was always referred from a tertiary center, and they send that there is no pulse, immediately go to Ganga Hospital. And if we examine the child thoroughly, sometimes you will see that there is very good perfusion, and sometimes you also feel the pulse back. And since ours is a trauma hospital, some of the person who are trauma registrars or fellows in the casualty, they examine the child and they write this as active finger movements present. So this is one of the common problems which we face. So the child will be moving the fingers like this, and they say that active finger movements present. This is exactly not what you should do when you see a child. You should do a thorough examination. And obviously you can see that this is, though the child is moving the fingers nicely and it is looking pink, we know that there is much more to it than what we see, obviously. So we should look for the what we call the OK sign. I'm sure that Nirmal touched upon this. So OK sign is basically you ask the child to do this, where you can assess almost all the three nerves, and there is a anterior intraosseous nerve is one of the most common nerve injuries associated with the pulseless supracondylar humerus. And if the child is not able to do this, you know that there is an anterior intraosseous nerve or a median nerve injury. There is a sensory disturbance as well. So that is the OK sign. So we say that the child is in a lot of pain and I'm not able to examine the neurovascular status and things like that, but that is not an excuse. You should find some way and means to do at least the basic neurological examination and document whether it is there or not, because it is very important, one in decision-making process, as well as in a medico-legal perspective also, whether the child had a neurological injury when it presented or not is very important. So you should spend some time to do a detailed neurological examination. Next, we will come to the injury patterns, how it differs, and the neurological presentation. We should know that the posteromedial versus posterolateral ones. The posterolateral injuries are usually associated with the radial nerve, the median nerve, and the brachial artery injury, whereas the posterolateral ones are associated with the radial nerve injuries, and the flexion type injuries are associated with the ulnar nerve injuries because of the proximity of the neurovascular bundle. And the patho-anatomy here is in an extension type fracture. You have the anterior spikes, the sharp spike here, which can hit the neurovascular bundle here. So that is the patho-anatomy in a pulseless supracondylar humerus fracture. And this injury can be anything. It could be just a spasm. When the spike hits the vessel, the vessel can go into a spasm and the pulse can disappear down. So it can be just a spasm. Sometimes it will be an intimal tear, where again there is a tear. Along with that, there is a thrombus formation in the vessel, or a compression. You can have a fracture hematoma which is compressing, and sometimes it is transaction. Complete transaction is a very rare phenomenon. The compression can be due to many structures. It can be due to the fracture fragment itself, or sometimes when we open, we see that there are some fibrous strands which is actually compressing the vessel. When you release the strand, then the pulse comes back. So it can be anything. Next comes the issue of perfusion. Why the Shyam rightly told that she will assess the perfusion before deciding on how to proceed with the injury. So we all should remember that the elbow has a very rich supply of collateral vessels. So the collateral supply is very rich, such that even if there is a complete transection of brachial artery, the distal perfusion can be completely maintained. So the collateral circulation can maintain a good circulation for the forearm muscles as well as the hand muscles. So in fact, there are papers which have studied that when they do a brachial artery repair following a supracondylar humerus fracture, and then they studied what happens to the repair. There was one paper by Dr. Sanjeev Sabharwal which says that up to 70% of them again restenosis, and it is actually the collateral circulation which maintains the distal circulation. So you have to remember about the rich collateral circulation around the elbow joint. But having said that, you also should remember that there are papers which says that the collateral circulation or the arterial anatomy around the elbow joint is not consistent. So there can be variation in the anatomy in 20% of the limbs. So there is no guarantee that the collateral circulation will give a good perfusion to all the muscles. Particularly the deep compartment of the forearm muscles can suffer vascular insufficiency when the collateral circulation is not rich. So this actually brings up the debate of whether we should just believe that all children without pulse in the supracondylar humerus fracture has a good collateral circulation or not. So it is important as a surgeon for us to assess whether this particular child has a sufficient collateral circulation and a sufficient perfusion. So that there comes the importance of assessing the perfusion of the child, perfusion of the limb for that particular child. So with that, we will just go through a case example. This is an 8-year-old child who presented at 7 o'clock in the evening, and there is no pulse on arrival. So classical type 3 supracondylar humerus fracture. This is a sort of X-ray which they come. Most of the times we see that there is no AP view. It's always like oblique and lateral view. So I asked Shinam already the same question. She rightly said that she'll assess the perfusion. So Shyam, can you tell me how will you assess the perfusion? What are all the things which you do to assess the perfusion?
Yes, sir. Sir, I will see, firstly, I will see capillary refill.
Okay.
And I will check with pulse oximeter.
Okay. Pulse oximeter, what, you check the saturation of how much is the cutoff, and for capillary refill, how much is the cutoff you keep?
Sir, 3 seconds.
When will you? Okay, good.
And I will also check the I will also palpate radial artery if it is.
Yeah, so the pulse is not there now. Yeah, pulse is not there on palpation. So you assess the perfusion. That is the reason why you are assessing perfusion. I want you to tell the other people who are listening how you assess perfusion. One is definitely you look at the capillary refill time, and the capillary refill time is less than 3 seconds. Definitely, it is good perfusion. And often it is very easy to compare with the opposite side. You compare with the opposite side, the capillary refill time, and you'll be able to appreciate it much better. The second is the SpO2.
Yes,
anything
sir.
else?
Sir, I will also. That's it.
Okay. So the most important take-home message from this will be you should always objectively assess the perfusion and not subjectively, because it is very difficult to say which hand is well perfused by looking at the color of the limb. Just saying that the hand is pink, so it is well perfused, is not enough in my opinion, because we have seen that it is not the same for a well-looking hand which is pink in color and it is poorly perfused, or a doubtful perfusion can be there. So these are the three things. One is the capillary refill, SpO2, yeah, saturation more than 95%. And also the other important thing is we look at the waveforms, whether the waveforms is good or not. And the third thing, which is very useful in our hands, is the handheld Doppler, which is a very small device, which we keep in the emergency room itself, which you can use to look for the pulse of the Doppler pulse of the radial end. So sometimes what happens is clinically the pulse is not palpable, but your Doppler can pick up the signals. I'll just go through each of this. So this is the normal capillary refill. You can see this is a normal hand of a child. Actually, this is a hand of a child with the pink pulseless hand. This is the normal side which I'm showing. And this is the normal capillary refill. This is what we call it as a good waveform. You can see the peaks nicely and it is uniform, and the saturation is 100%. Okay, so you should look for this. This is a very useful tool, though this is not published widely. And I think particularly most of the publications about the pink pulseless hand is from the Western world. And in the Western world, the SpO2 may not play a great role, because the weather there is different, and most of the places are cold, and they feel that the SpO2 probe may not rightly pick up. But I'm sure if they do a proper RCT, I think this is a very valuable tool. The problem will be only getting the numbers. So there is only one publication from Singapore, I think from KK Children's Hospital in Singapore, which they have studied the use of pulse oximeter to assess the perfusion of the limb, and they've shown that it is very useful. And we also have found that it is very useful in decision making. The third thing is the handheld Doppler. So this is the handheld Doppler machine. I hope you're able to hear the sound of the Doppler, right? So this is, again, it's very useful. If you know that the pulse, the Doppler is picking up the pulse, then you know that it is well perfused. So in the emergency room, we gently reposition the limb and immobilize. And whenever there is a pulseless supracondylar, usually the trauma registrar calls us, we reposition and reassess the pulse and perfusion of the limb by whatever we discussed now. So this is typically what my fellow does. If when a child comes with a fall, this is a WhatsApp message. He sends me. Now you can see that this is our protocol now. That he has to send a picture with the waveforms and the SpO2 and the X-ray, so that it gives a proper idea to us whether the limb is perfused or not. So this is actually a good way to know. Even if you are not in the hospital, your consultant will be able to take a good decision whether the child has to go into the OR immediately or not. We'll come to that later. So this is the appropriate use criteria published by the American Academy of Orthopaedic Surgeons. And so this is basically that a vascular consult should not delay the reposition or reduction and fixation. You should not think that you should get a opinion of the plastic surgeon or vascular surgeon before you plan for fixation. It should not delay the reduction and fixation. A qualified clinician may reposition and reassess perfusion. That's what we said. So the fellow can actually reposition and reassess the perfusion. Regardless of return of pulse, admission for close reduction and pinning and observation is recommended. And if it is pulseless and if you don't have support of microvascular team, and this part is actually a little dicey because we are talking about all the patients who are pulseless. It should be actually if there is a doubtful perfusion, and it is better to have a microvascular support. So if it is not there, you may consider it transferring to another facility where it is available. I will come to that in detail a little later when we are discussing the algorithm. Back to our case. So this patient was planned for immediate close reduction and percutaneous pinning. So these are the images which you have after the close reduction and pinning. So I'm going to show the video of the hand which was pinned. So you can see that is a normal side where you see the capillary refill is nice and quick, less than 3 seconds. And this is looking pink or pale, whatever you call. But the capillary refill is not satisfactory. You feel that there is a difference definitely. And you can see the difference in the SpO2 signals as well as the waveform. This is a flat line. It's not picking up at all completely. I'll just play this. So on the SpO2 is not picking up completely. So we know that there is a problem in perfusion now. The pulse is not palpable. The perfusion is not good. So this child was decided for exploration, and we found that there was a thrombus which was removed, and then an end-to-end anastomosis of the artery was done. So by definition, a pink pulseless hand is a hand that remains pink and pulseless after close reduction and pinning of a pulseless supracondylar humerus fracture. That is what is called as a pink pulseless hand. So after reduction and pinning, if the hand remains pulseless, then you call it as a pulseless supracondylar, which is pink. So if it is pale, there is no question. So there is no problem in deciding. If it is pale, you directly have to explore. But if it is pink, then the management is controversial. So all the papers which are published in literature are about the pink pulseless hand. The color of the hand is pink. Not a lot of them have discussed about the perfusion as such. So you have 2 papers which recommend early exploration, including the recent one from White et al., which is actually from Cincinnati, where they did a systematic meta-analysis, and they found that about 70% of the patients with a pink pulseless hand can have a significant arterial injury, and they recommended early exploration in all of these children. So the rest of all papers, this is Perumal et al. Is from our institution, which we published in 2011. So all these papers recommend actually observation when you have a good perfusion. But if you look at the AAOS guidelines, it clearly says that we cannot recommend for or against exploration in a well-perfused hand. So still, there is no strong evidence to say that you can observe. So it is still this way and that way. So this is the paper which was published from Cincinnati, and you can see that about 70% of this pulseless perfused fracture had documented brachial artery injury. So, and this was actually discussed a lot when this paper was published, and the conclusion, they recommended that these fractures should be, the common dogma regarding watchful waiting needs to be questioned. So they recommended exploration. And this is again still controversial because there is a dilemma between plastic surgeon and the orthopedic surgeon. Even in our institution, if we call the plastic surgeons earlier on, they always tend to have a opinion that they should always explore when the pulse is not palpable, because they don't believe that if the pulse is not there and the Doppler is not picking up the arterial signals, the hand can be well perfused. Even when we published that paper in 2011, there was lot of unhappiness from our plastic surgery colleagues, and how can you publish saying that it can be observed? So we generally don't call them immediately when we see a child with a supracondylar fracture without pulse. So what we do is, when you see a child, you assess perfusion, and if there is good perfusion, or if you have a doubtful perfusion, these are the two different scenarios which you can have. So when the perfusion is good, you have to do a close selection and pinning. If there is doubtful perfusion, again the treatment is not going to change. But you should remember that if the perfusion is doubtful, it is better to have a vascular backup. So you should remember this. And even if the perfusion is good, it is not a good idea to wait till the next day morning. So whenever there is a pulseless supracondylar humerus fracture, even if it is in the middle of the night, even if it is well perfused, I feel that it is important that we plan for an emergency close reduction and pinning at the same time. There is no real advantage of waiting till the next day morning, and it is not a good idea to wait, because it can, anytime the perfusion can change, and in the middle of the night it is impossible for us to monitor the circulation continuously. So our recommendation is that even if the hand is well perfused, it is important that you take in the child at the middle of the night. Whenever the child comes, you just have to take it inside for a close reduction and pinning, and after pinning, you reassess the perfusion and decide what needs to be done. So what are all the possibilities? So what are the odds that the pulse can come back after your pinning? That is the first question. So second question is, what if the pulse does not come back? That we saw a case example. I'm going to touch upon, based on our data, I'm going to show what is the answers for these questions. And my patient has a median nerve injury, associated nerve injury is there. So should I explore? Does it come into the picture that if there is a median nerve injury? There is one paper which says that if there is a median nerve injury along with the pulseless supracondylar, you should always explore. It is better to explore. And what are all the final question is, what are the definitive indications to explore as fellows we need to know? So I'm going to give answers to these questions based on our data of last 14 years. So we had about 66 pulseless supracondylar humerus fractures in the study period, out of which all of them underwent immediate close reduction and pinning. And actually this number 66, actually it is 14.5%. So if you look at the literature, 10 to 15% is the incidence of neurovascular injuries in any supracondylar humerus fracture. So our incidence was 14.5%. And in that, 30% of them, the pulse came back after close reduction and pinning. So there is a 1 in 3 chance that you see a pulseless supracondylar humerus fracture, you do a close reduction and pinning, the pulse can come back. But the 70% chance that the pulse is not going to come back. So if the pulse is not coming back, what are we going to do? So if you look at the 48 patients who had a persistent pulselessness, in that we assessed the perfusion. Again, 80% of them, 40 of them had very good perfusion. So not all of them had the radial Doppler documented, but all of them had SpO2 with more than 95% with good waveforms, which is documented in the case sheet. And also all of them had capillary refill, which is good, less than 3 seconds. And except 7 patients, the rest 33 patients, all of them had a handheld Doppler radial artery signals, which is picked up. So all these patients were just observed and nothing was done. But it is important that you admit them, at least keep them for 48 hours under observation. The rest 8 patients, which is like 17%, or we can say that it is 17 to 20% of them, which had poor perfusion, were taken up for exploration. So the next question is, my patient has median nerve injury. Should I explore? So this is actually the first paper by Mangat et al. In 2009. So he suggested that if there is a nerve injury, you should always explore. And this is a review article by the Peter Waters group from Boston. Again, in this article, which was published in Journal of Hand Surgery in 2013, in this, they gave a good algorithm. And in that algorithm, they said that if there is a median nerve injury associated with the pulseless supracondylar fracture, they would tilt on the side of exploration rather than observation. So that was the sort of conclusion which was given in this paper. So what is our experience? We had 21 patients with median or anterior interosseous nerve. It is just not pure median nerve. All these patients, at least 16 patients had anterior interosseous nerve, and the rest 5 had median nerve, I think, if I'm not wrong. Out of this, actually, if you see, 16 patients with the nerve injury were in the observation group, which is like 75% of the patients with nerve injury was just observed. Only 25% was in the exploration group. So this is actually, when we did the statistics, it was not significant by p-value. We did the Fisher exact test and we found that the presence of median nerve injury is not a very significant factor for you to take a decision that you should explore based on these numbers. And this is exactly what was published by David Skaggs and group. This was an article published in JPO in 2019. They also found that retrospective study again, 70% of the patients with nerve injury were just treated by observation. So they also did not explore. So definitely the presence of an anterior interosseous nerve injury or a median nerve injury along with the pulseless supracondylar fracture is not an absolute indication for you to go ahead and do a open exploration of the neurovascular bundle. So that brings us to the final question of when do you definitely need to explore? So we know the answer, obviously, that if the perfusion is poor, but I would like to put it in this way. A poorly perfused hand to start with, which remains poorly perfused after close reduction and pinning. So that is a definitive indication. The second indication which we have seen is a hand which is well perfused. So you see in the emergency room, you think that the hand is well perfused, but still there is no pulse. So you take for emergency close reduction and pinning. And after pinning, you reassess the perfusion goes off. So you know that there is an entrapment of the neurovascular bundle at the fracture site. Sometimes it can happen. Even if your reduction is looking perfect, 100% perfect reduction in the C-arm, if your perfusion goes off, you should always suspect that there is something going on inside, which you cannot leave it like that. So this is again a definitive indication. So for this one reason, we should always remember that whenever you see a child with a pulseless supracondylar humerus in a casualty, and you should have, there is a remote possibility that the perfusion can get worsened after close reduction and pinning. So for this one reason, I feel that it is better to have a vascular backup, or at least you should have an access to a plastic surgeon or a vascular surgeon who can come and explore if it is needed. So if you don't have that facility, it is better to refer the patient to another facility where it is available. So this is a 2-year-old child. So now we know that the incidence of supracondylar humerus age-wise, it is decreasing and decreasing. We are seeing patients at 1.5, 2 years. I think you also must be seeing the same, because previously we used to say that 5 to 15 years is the incidence, but now we are seeing patients at 1.5, 2 years. It's very common. It's a 2-year-old child who came pulseless on arrival. So it is surprising. 2 years, there is no pulse. So this is a child, and you can see the waveforms here. It is good. So 100% saturation. So pulse is not there, but perfusion is good. So you take for close reduction and pinning. So this is what was done. This was done by our fellows. After reduction, you see this is a flat line. There is no waveform, and the capillary refill is not good. The Doppler is negative. So Shyam, what do you think? What is happening here? What will you do?
Sir, it may be we can do close reduction after.
No. This is after close reduction. So this is the previous picture where the perfusion is good. So as you told, we looked at the capillary refill, which was good. The SpO2 signals are good. Waveform is very nice. So this is a good perfused hand. So we did pinning. So this is the pinning picture, CM pictures actually. So
Yes,
this is a reasonably good job. And after pinning, it's a habit for us always. You have to palpate for the pulse, whether it has come back, and then you put the pulse oximeter probe and see what is happening. And this is what is the picture you get immediately after pinning.
Okay,
so you are the person who is, you are the person who is doing the case. What will you do? Will you call Maulin immediately?
Sir, I will observe for 24 hours, and then I will take some decision whether to explore or not.
So why 24 hours? What is the no scientific reason behind waiting? So do you have any doubt about that this hand is, what do you think is the perfusion status of this hand now? So there is decreased CRT. So
yes,
the Doppler is not picking up the radial artery pulse. I'm not able to palpate the pulse. And this is the SpO2 signals and waveform. It is flat, completely flat. Nothing is picking up.
Yes.
So anybody else who are fellows can pitch in and answer. What will you do? If you are the operating surgeon here, what will you do in this situation? Okay. Nobody?
Sir, Gaurav Gupta, sir. Yes.
So since there was perfusion before
close reduction, and now the perfusion has gone. So it tells us that there might be some the vessel might have got stuck in between the fracture fragments, or something has happened to the something has happened to that flow. So we should
Agreed.
not wait, and we should call the vascular team and do the exploration.
So sort of I agree with Gaurav, but before calling the vascular surgeon, Gaurav, how long you think you will wait? When will you say that this hand is not going to get this perfusion back? So this is immediately after pinning, right? So
Yeah.
you finish the procedure, even before applying the slab, you put the pulse oximeter probe into the hand and see that this is coming. Will you call the vascular surgeon immediately, or you wait 5 minutes, 10 minutes? What is your cutoff? That is what
So,
I want to know.
sir, I would wait for a couple of hours, but then I don't know the exact time till
Okay.
when.
So no, I am asking in practical way. I'm asking. So I would say that, so this is actually an unanswered question. How long should you wait? Because
Right.
the more you wait, your muscles are going to get ischemic, right? So the
Six
this
hours.
yeah, 6 hours is too long because the muscles can necrose in 6 hours. So we do not have a no quote unquote that number exactly how many minutes or how many hours to wait. But what we do is, see, there are certain things which you should remember to do before calling the vascular surgeon. One thing is, we often pin the limb in abduction. So if you position the patient on a fractured pin that on the table and you put the arm board for pinning, whatever thing, so the limb is in abduction, 90 degrees of abduction. So if you see in abduction, the pulse may not be palpable and the perfusion can be poor because the vessels are stretched. The axillary vessel comes from here. This we have seen because this is out of experience, I'm saying. So we felt that the perfusion is not good. Then we shifted the patient to the plastic surgery OT. We adducted the limb and then we checked the perfusion. The pulse came back actually for a patient who was shifted to plastic surgery OT for exploration. After just keeping the limb shoulder in neutral position, the pulse came back within a matter of 5 minutes. Okay, so first thing is you decrease the abduction, keep the shoulder in neutral position. Your elbow should be kept in 30 degrees of flexion, shoulder neutral, then reassess the perfusion. The third thing is you have to put a warmer on. You have to warm the limb, because if the theater is actually, we are always working under the AC, the limb can be cold. The pulse oximeter signals sometimes cannot pick up if it is the limb is cold because of the peripheral vasoconstriction. So you have to put a warmer on, warm up the limb nicely. And what we typically do is wait for at least 20 minutes. Okay, 20 minutes, we feel that it is a good time. And in that 20 minutes, if the pulse is, if the perfusion is not coming back, and if you are not able to pick up the radial artery Doppler signals, then probably there is an indication to explore. 20 to 30 minutes is our cutoff. After 30 minutes, if the line remains flat, the SpO2 is not picking up, the CRT is bad. After doing all the measures which I told, if still it is doubtful, and since we have the facility, we tend to explore. But I feel that should be the protocol anywhere else, because whenever there is a doubtful perfusion, there is no point in sitting on it. And most of the times it will be just like a, excuse me, in a well perfused hand, it should be like an entrapment in the fracture site, which can be easily dealt with. So you don't need a very skilled vascular surgeon to do a end-to-end anastomosis there. So in this particular patient, it was just some fibers, a fibrous strand which was compressing the artery. The artery actually was not entrapped in the fracture site. So there was a fibrous band which was compressing the neurovascular bundle. Once that was released, you can see the pulse here and the saturation in the waveforms here, which came back nicely. So this was, this did not take much time. You don't need a very skilled vascular surgeon, but then you don't know which patient will have a transaction. So it is better to have a vascular surgery backup. But we have seen that, I'll come to the data of how many had real arterial injury in our patients, 8 patients who underwent exploration. So this was the picture in this child. We have seen that many of patients just have some compression or entrapment at the fracture site. So we have explored 8 patients. In all 8 patients, the radial artery Doppler was not palpable. The pulse oximeter signals was less than 80 with irregular waveforms. And 5 out of these 8 patients had associated median nerve injury. And if you can see the data, only 2 patients had significant brachial artery injury, which needed a microvascular work. One patient, which I showed earlier, had a direct repair. The other patient was a bigger segment, which was repaired with a saphenous vein graft. So out of the 8 patients, only 2 needed vascular. work, which is a good news. No, over a period of 13-14 years, I'm saying. The rest, all 6 patients, it was either the kinking of the vessel at the fracture site or the fibrous strand, which is compressing the neurovascular bundle, which was released and the pulse came back. So that is the kind of data which we have. So this is the last case which I have put. The 13-year-old boy, again, pulseless hand, doubtful perfusion. This is after pinning. And yeah, this is a good perfusion after pinning, right? Your saturation is good. Shyam, what do you think? The waveforms are good, right?
Yes,
So
sir.
you're happy with this. And the hand is also looking pink. But this is a radial artery Doppler. I was not able to pick up the radial artery Doppler signals at all. And what will you do in this situation? Your perfusion is good, but radial artery is not palpable, and even the Doppler is not picking up. But your
Sir,
SpO2 signals is good, and CRT is good, less than 3 seconds.
sir, we can wait
Right,
as
exactly.
collateral circulation will.
Good. So now we know that this hand is perfused well. So we don't have to, it is not like the previous patient. So here we see the saturation is more than 95%, the waveforms are good. So we don't have any doubt about the perfusion here. So only small little tip is, if radial artery Doppler is not, you're not able to pick up, what I would suggest is for all patients, you should check for the ulnar also. This like, so this is the same patient, you check on the ulnar side, and we've actually picked up the Doppler signals on the ulnar side. So I think you can hear that. So you have to remember that if you are using a handheld Doppler, or even you can use these, I think most of the institutions might have ultrasound machines for anesthesia, regional anesthesia. Now they have ultrasound machines anesthetists have in the preoperative ward itself. So you can actually use those machines also to trace the vessels, or you can do a Doppler with the same ultrasound and you can see whether the radial and ulnar artery is there. So remember that it is not just the radial artery signal. Even if ulnar signal is picked up, we know that the hand is going to be perfused. The hand and forearm does not need both radial and ulnar artery. Even if one artery is there, it is good enough for maintaining the perfusion. Okay. So to summarize, whenever you see a pulseless supracondylar humerus fracture in the emergency room, you plan for emergency close reduction and pinning after assessing the perfusion. So you reposition the limb carefully up to 30 degrees of flexion, immobilize, assess the perfusion. And if the perfusion is doubtful, you immediately inform the vascular surgeon, say that, so we have a supracondylar humerus which is doubtful perfusion, we might need your help. So that's how it is. If the perfusion is good, we take for pinning, and after pinning, if the perfusion goes poor, like the case which I showed, then we inform the vascular surgeon. So that is how it helps. In the emergency room itself, you can assess the perfusion. After pinning, if the pulse comes back, it is like any other supracondylar fracture. The only difference is you can't discharge them the next day itself. So better to keep them for 48 hours, because it's a violent injury when the pulse was not absent. So we tend to keep for 48 hours. Again, the evidence is not there for that. And if the pulse does not come back, you reassess the perfusion. You can have 2 scenarios: well perfused, inpatient observation, look for the pulse. Again, you keep them for 48 hours. If the perfusion is doubtful, you explore. And you have to remember that while reassessing the perfusion, these 3 things which I told you have to keep the shoulder in adduction, elbow in 45 degrees of flexion, and you use the warmer, nicely warm the limb, wait for 20 to 30 minutes before you take the decision that this limb needs some help in form of exploration of the neurovascular bundle. So with this, I have some more cases of nerve injuries. If we can take questions, and if there is time, we can move on actually.
Yeah, thank you, sir, for this very, very detailed assessment and understanding about how to manage pink pulseless hands. And it gave a lot of clarity to me, and I hope it has given to all of us. So now I would like Sheenam to ask if there is any question that can be done.
Yes, sir. Sir, one question is from Anil Agarwal, sir. in case the vascular surgeon not immediately available, would undoing the reduction help?
Well, undoing the reduction alone. Huh? So I think this question is after reduction if the pulse goes off and if vascular surgeon is not available. I mean, if your reduction is not good, if like the one of the cases which I showed, if there is a step off, the fracture ends are not perfectly opposed, then probably we can think that the fracture, no, neurovascular bundle is interposed. In that situation, you just remove the pins and undo the reduction. It might help. But if your reduction is perfect, if there is an end-to-end opposition, then you know that the problem is not that the vessels entrapped at the fracture site. In that scenario, like the other case which I showed, where we lost the perfusion, the reduction was good. In that case, undoing the reduction may not be of great help because it is not going to make any change. That is my opinion, because the fibrous band which is there anteriorly only is compressing the vessel. So I really do not know whether that will be of much help. So it again depends from if radiologically your reduction is not good and you feel that there is a gap at the fracture site, definitely removing the pins and then undoing the reduction might be of help. Yeah. There
Next,
is, yeah, one more question is there from Dr. Punit Pai, right?
yes.
Yeah. He has asked whether there is a role for CT angio, and the answer is no. I mean, there's a lot of studies which have been done. Apart from the the value in decision making, the other thing also you to remember that it's a child and CT has got a lot of radiation, which is not worth it in this situation. It's not going to help you to decide anything at all. So even if you find that there is a complete transection of the brachial artery in a CT angio, it ultimately boils down to the fact that whether you do a artery repair is or not is decided only based on the perfusion of the hand. So I don't think that there is any role for CT angio at all. So the answer is a big no. Yeah.
Sir, collateral circulation, is it robust enough?
Yes. So, I mean, as I showed, 80% of the times, if the arterial anatomy is normal, it is good enough to perfuse the hand. 20% of the patients can have anomalous arteries and they will not have good perfusion. And I feel that those 20% of the patients are the ones who need sort of exploration. So unfortunately, we don't have numbers to say because the total number of exploration itself is 8 only. So if you pull in data, we may be able to say exactly. I feel that 80% will have good circulation, definitely. That is what the literature also says.
Okay, sir. Sir, in one more question, in case waiting for close reduction, any tips for gross alignment?
I mean, in case waiting for close reduction. So
Sometimes, yes, sir.
So if the patient comes late, I think that's what Dr. Anil mentions, if I'm not wrong. No, I think the reduction tips. I mean, I don't. I can't get the question exactly what he wants, but if
Sir,
it is,
it happens. Can I put the question again? The
yeah,
patient
sure.
comes at 3 a.m. not fasting, and then
Okay.
sometimes the OT is busy because of other reasons. So, and you have a waiting time of 6 hours. Anything we can do to help the child meanwhile?
Yeah, I think.
For surgery, we have planned for close reduction, but sometimes the OT is not rightly available.
That's a very practical situation which happens in our country. Sometimes we don't get the OT. So only thing is that you can keep the limb in 30 degrees of flexion and immobilize it. And you just have to wait and see. I mean, there is nothing much we can do. There is without anesthesia, you can't do any other maneuvers in the emergency room or in the pre-op waiting area. That is a problem, right? So you just excessive flexion definitely is going to kink the vessel. 30 degrees of flexion is a good position. We put a slab in 30 degrees of flexion, keep the limb warm, and just see how the perfusion is there. You can put a SpO2 probe on to be sure that it is. If there are two scenarios, one, if the perfusion is good, it is going to maintain because we are not disturbing anything. If it is poor, you feel that you have to take the child inside immediately. So you have to, you will find some way, way to sneak in the child immediately on the next available operating room. So that's in that way it is definitely helpful. You just put a SpO2 probe and keep watching it. If the saturation is not picking up, we know that the child needs immediate help. So yeah.
Okay, sir.
Yeah,
That's
so
it for the question. Yes.
I think now there are no more questions. So, sir, we have around 15 more minutes. So, if you
Yeah,
can
I will
share
just
some.
go through the nerve injuries a little bit. I've just borrowed these slides from our plastic surgery colleague, Dr. Praveen Bharadwaj.
Okay, sir.
So we touched in detail about the vascular injuries associated with supracondylar humerus. What about nerve injuries? Isolated nerve injuries are not uncommon. So we see patients just presenting with anterior interosseous nerve injury with the pulse. So pulse is present, but there is associated nerve injuries. As we saw that you can have a radial nerve injury, ulnar nerve injury, anything without associated vascular injuries. So in those scenarios, is there a recommendation to explore the nerve immediately? So that is one question which you can get in the examination, or as a fellow you should know as a practically what we should tell the parents. So most of the times you see the child is not able to do this, or okay, so and the parent asks, so you fix the fracture, should you do anything for the nerve? So again, this is a paper which is from the Peter Waters group in 2017, which says that majority of the nerve injuries associated with the extension types of procondylar fracture recover within 6 months of time. So, and there is no need for acute nerve decompression. So, isolated nerve injuries, any nerve, be it median or anterior interosseous or ulnar or radial, there is no indication to explore the nerve. So, this is the first point which you should remember. So, if the vessel is intact and the nerve is gone, most of the times it recovers. You can tell the parents that we are going to wait and watch. Most of the times it recovers, and if it doesn't recover, we'll do the necessary. So the waiting time is usually around 4 to 6 months time, and as we said, within 6 months time, most of them recover if it is a nerve injury. So the other nerve injuries which we face is after pinning. So it is not uncommon to see cross pinnings or a medial pin with two lateral pins in unstable fractures. And post pinning, the child develops a ulnar nerve injury. So that is also a scenario which you should remember. You do a pinning, the child develops ulnar nerve injury. What you should do? So that is another question. I'll give the answer as we go through this case. This is a child which was pinned elsewhere. So a decent job with the reduction and the pins as well. Two lateral pins and one medium pin. And 4 months down the line, the fracture healed well. This actually was missed outside. After the medial pinning, they post-operatively, the ulnar nerve injury was not documented in the outside case sheet. And the child presented to us with at 4 months with total sensory loss and severe ulnar clogging. So this is the picture. So now is it going to recover? So we saw in the initial paper that up to 6 months you can wait, but you have to remember that that is without any intervention, that the fracture by itself has caused the nerve injury, which most of the times is a neuropraxia, which is because of stretching of the vessel. But here it is your pin which has caused the ulnar nerve injury. So the scenarios are completely different. So whenever you have a nerve injury post pinning, so this is again another paper which was published in BJJ in 2016. So if there is a presence of a complete nerve palsy with positive tenal sign neuropathic pain, then you have to consider vascular exploration. We know that there is a significant nerve injury which needs to be explored. Okay, so and if you look at the long-term functional results following nerve injuries in pediatric supracondylar humerus fracture, and which nerve recovers better, 100% of the radial nerve injuries usually recovers, and 87.5% of the median nerve injury completely recovered in 6 months time, within the 6 months time. But whereas in ulnar nerve injuries, it's only 25%. So the recovery rate is very less in ulnar nerve. That also you should remember. So this child was taken up for neurolysis. This is actually the pin which has gone through the nerve, and you can see the fibrosis here. And they did some fascicle repair, I think. So that was how the nerve was repaired. I'm not a microsurgeon. This was done by Dr. Praveen Bharadwaj, and that's the kind of function. If you do at the right time, you will be able to get back the functions in a very nice way. So with this, I think I finished my presentation. Thank you for the kind attention. And I can take some more questions.
Yeah, Sheenam, are there any more questions now? Sheenam?
Sorry, yes. After reduction, at what degree you give cast?
I don't give cast. We always put a slab. And in pulseless supracondylar fractures, it is about 60 to 70 degrees of flexion. That's what we do. And even in all routine supracondylar humerus fractures, I don't cast them. Even without pulse or with pulse, I usually give a slab and convert them to a cast after a week's time. That's our protocol usually, because we don't want to sort of take chance. I think this the other interesting thing which we have seen. Actually, we are trying to look at it more this way. We are looking at the functional outcomes of all the patients who had pulseless supracondylar humerus fractures. The same data of 66 patients. We did an initial telephonic interview with a quick dash, and it was interesting to see that the patients who had explorations had a bit lower functional outcome compared to who had observation. So it is a very interesting thing. And we are in the process of calling all the patients back to do a detailed assessment of the functional outcome. And that will be interesting to see, because we feel that the patients who had exploration need not be faring better in terms of function as well as grip strength and things like that. I think they should be comparable, or the observation group will be doing better than the exploration group. Yeah.
There is one more question, sir. Do you prefer medial pin or a Dorgan pin regularly if needed for fracture pattern?
Yeah, that's a good question. So if there is an unstable fracture, which is rotationally unstable, or a medial comminution, I prefer to put a medial pin. I don't use a Dorgan pin on a routine fashion. So in my hands, I think if you're careful enough to put your thumb over the medial epicondyle and push the nerve posteriorly, keep the elbow in like 30 to 40 degrees of flexion. You don't flex. If you flex more, you are going to get the nerve anteriorly. So 30 to 40 degrees of flexion, you keep your thumb and push it posteriorly, you will be able to safely put the ulnar nerve. I usually take the wire in the hand and then puncture it, and then you put the driver inside and then drive. I directly don't do this with the gun. So in that way, I feel that it is quite safe to do. If any doubt is there, probably you can do a mini open and go to the medial epicondyle and then do it in a safer way. It is not a major problem. The Dorgan spin, it is a good technique, definitely, but the issue is you are blind completely, and your trajectory also is sometimes difficult. You are keeping the limb like this, and you have to put the wire. So you will have to adduct the limb to drive the wire in that trajectory, because you have to put it in at least a 45 to 50 degrees of angulation. So it can be difficult to put a Dorgan pin in a fracture situation. Sometimes you might get I think it's one of the reported complications is a radial nerve injury. So you don't want that to happen, no? I feel between a Dorgan pin and medial pin is much more predictable, and I can put it in a safer way rather than a Dorgan pin. Yeah.
Right, sir. Thank you, sir, for all the answers. So I think there are no more questions now, and we are finishing well in time. Thank you for all the clarity you have given to us. And now I would like Sheenam to conclude the session.
Thank you, sir. It was great pleasure to learn from you. If anyone has any question about anything, you can post in the group also.
Yeah, sure. I'll be happy to answer.
Yes, sir. Sir, I also saw your one paper on atypical supracondylar fracture published just January 2022.
Yes. So that is more about unstable fractures and atypical ones, which you see where we use different methods of reduction as well as fixation. So it's a
Yes.
free PDF, I think. so I can share it if it is not there in the group.
Yes, sir.
Thank you so much for having. I had a very nice Saturday morning. It is good to know. I enjoy teaching actually. So it was a very nice session, very interactive.
Thank you so much, sir.
I wish
Thank
Maulin
you,
was there.
sir.
So we actually missed Maulin. You should convey the message to Maulin.
Yes, sir.
Sure,
Thank
sir.
you all.
Sure, sir. We'll
Yeah,
rope
all
you
of you
in
have
for a
a
few more lessons, sir.
sure. We'll be happy. So all of you have a good day and a good
Thank you,
weekend.
sir.
Yeah, see you sometime later. Bye.
Thank you, sir. Bye.
Thank you,
Bye.
sir.
Bye.
Thank you, sir.
Bye.
I think we should wrap this up now.